In this talk, we will look at a few immunological cases that you are likely to encounter in the emergency department and which are also of some relevance to your examination. So, the first case is a 47-year-old male patient who presents to the emergency department with a swollen tongue and difficulty swallowing. And you can see a picture of the patient's mouth and tongue on the right. So what I'd like you to do is list two mechanisms by which this condition might arise, describe the pathophysiology of each of these mechanisms, and how you would treat them. Pause the video, see if you can answer these questions. Okay, so in the West Indies, a common cause of that kind of swelling of the face and tongue, which is of course angioedema, is ACE inhibitor-induced angioedema. ACE inhibitors are antihypertensives that work by blocking the conversion of angiotensin 1 to angiotensin 2 through their inhibitory effect on angiotensin converting enzyme. However, this same enzyme is also important in the breakdown of bradykinin to its inactive metabolites. So, in the normal inflammatory process, large molecular weight kininogen is broken down into bradykinin through the enzyme kallikrein. Bradykinin is one of the more important inflammatory mediators, producing vasodilation and increased capillary permeability. It is removed from circulation through the action of angiotensin converting enzyme, which converts the bradykinin to inactive metabolites. So, the ACE inhibitors run the risk of also blocking this pathway sufficiently to cause a buildup of bradykinin and as a consequence acute inflammatory reaction, which can lead to tissue edema, particularly seen in the tissues of the face and tongue, but in other mucous membranes as well, such as the gastrointestinal tract and the pulmonary airways. The second mechanism of action of the swelling of the face and tongue that you saw in the previous slide would be anaphylaxis. Anaphylaxis is a type 1 hypersensitivity reaction, and the process has two stages. In the sensitization stage, antigen is presented to the body. It is then taken up by antigen processing cells, which present these antigens to T cells, and T cells sensitize B cells, B lymphocytes, to produce specific antigens against this, antibodies against this antigen. And these tend to be IgE antibodies. These IgE antibodies then attach to the surface of mast cells by their Fc receptors. The patient is now primed for any subsequent exposure to this antigen. In the effect stage, the antigen once again presents to the host. In this situation, the primed mast cells with their specific IgE antibodies on the surface are already in circulation, and when the antigens bind to these mast cell bound antibodies and cross-link them, this leads to mast cell degranulation and release of inflammatory mediators, which then produces vasodilation and increased capillary permeability. So as you can see, these two mechanisms for producing angioedema are quite different. In the ACE inhibitor-induced angioedema, this is not an allergic type or hypersensitivity reaction. It's a specific consequence of the loss of action of angiotensin converting enzyme, as opposed to anaphylaxis, which is a type 1 hypersensitivity reaction. And as such, the treatment can be quite different. The treatment for anaphylaxis is really the treatment for any acute hypersensitivity reaction, including the use of adrenaline, antihistamines, both H1 and H2 blockers, and steroids, and of course appropriate resuscitation. With the angiotensin converting enzyme inhibitor induced angioedema, these often don't work, and we have to use other strategies such as the use of fresh frozen plasma to to replace C1 esterase inhibitor, which can then inhibit this inflammatory response seen with the ACE inhibitor. The second case is a 43-year-old female who presents to the emergency department with fever of unknown origin, polyarthritis. She has a malar rash and discoloration of her sun-exposed skin. Her urine shows microscopic hematuria, and her blood tests reveal acute kidney injury. Her serological tests are positive for anti-nuclear factor and anti-double-stranded DNA, and the following is her skin biopsy. So you can see that this is an immunofluorescence stain, and it shows fluorescence rarely in the epidermal basement membrane. It should be noted this is a sample from the unaffected skin. Okay, so we want you to think about what's the diagnosis, the pathophysiology of this condition, if there are any diagnostic criteria for this condition, and if you can explain how the condition affects the cardiovascular system, the CNS, skin or kidneys. Pause the video and see if you can answer these questions. So this is SLE. SLE is a type 3 or immune complex hypersensitivity reaction. And the trigger for SLE is not completely known, but we think it's a combination of genetic factors or mutations in the host, and the impact of possibly UV radiation and infectious agents, particularly viral agents. This causes damage to and destruction of cells and release of nucleic antigens and interferon into the system. The nucleic antigens are taken up by dendritic cells, which are one of the antigen presenting cells, and then presented to T cells, which activate B cells to produce antibodies against these nuclear antigens. The antibodies bind to the antigens within the circulation, forming immune complexes, and these immune complexes deposit themselves in highly vascular areas, particular areas with high blood flow and high vascularity, such as the glomerulus, small blood vessels, and skin. deposition of these complexes leads to localized non-specific immune responses with release of immune modulators such as interleukins, cytokines, tumor necrosis factor. And this can produce a wide variety of different lesions in different parts of the body. In fact, SLE is such a ubiquitous disease that the European League Against Rheumatological Diseases, or the American College of Rheumatologists, got together and produced a set of diagnostic criteria. So these criteria applied to patients with an ANA, positive ANA of more than 1 in 80, and the criteria are divided into clinical and immunological domains. Each criterion has a weighted score attached to it, and when you're scoring for each domain, you only take the score of the criterion with the highest score. If the total score in the patient adds up to more than 10, and at least one of those criteria are clinical, then the patient is said to have SLE. And on the right hand side of this slide, you see a list of the different clinical domains and the signs and symptoms associated with them that might point you in the direction of SLE, and the immunological domains and the blood tests that we look at. Our final case is a 42-year-old female who presents with shortness of breath for 4 months and decreased exercise tolerance. A chest x-ray is here, and as you can see, there's quite marked hilar lymphadenopathy. Again, just pause the video and see if you can work out what this might be. So we want you to think about a differential diagnosis for a patient with increasing shortness of breath and hilar lymphadenopathy, and what further investigations you might need. We're not going to really discuss that now, but the transbronchial biopsy reveals non-caseating granulomas. So what we're going to talk about now is what's the likely diagnosis and the pathophysiology of the condition, and what organ systems might be affected, and further investigations. Pause the video, see if you can answer these questions. This is sarcoidosis. It's a type 4 hypersensitivity reaction. The activation of the T cells leads to further macrophage activation and granuloma formation. Epidemiologically, this is seen in black females and is also prevalent in some Scandinavian countries. We're not sure of the cause, but we think it could be genetic or some sort of chronic infectious disease such as a systemic fungal infection or mycobacterial infection, and there's clearly also an autoimmune component. This slide lists the widespread clinical features associated with this condition. Note particularly that there are often respiratory symptoms and skin symptoms as well, although other areas such as the RES and the CNS may be affected. Okay, so that was a quick look at 3 important immunological conditions. If you have any questions, you can bring them up in class. So in this talk, we looked at anaphylaxis, angioedema, SLE and sarcoidosis as some important immunological conditions that you will encounter in the emergency department. Thank you.